Stretching your shoulder is probably the worst thing you're doing right now. Not because movement is bad, not because you're fragile, but because most people stretch a shoulder that doesn't need more range. It needs more stability. And every time you pull that arm across your chest, crank it behind your back, hang from a doorframe, trying to feel something release, you're loading a structure that's already under stress in exactly the wrong direction. You feel temporary relief and call it progress. A week later, it's worse. You stretch more. This is the loop most people are stuck in when they walk into a physio clinic for the first time. Here's what's actually happening. Shoulder pain is not one condition. It's a category, the way knee pain is a category. There are at least a dozen distinct mechanisms happening in that joint complex, and most of them don't respond to the same treatment. What works for one makes another worse. Stretching, in particular, can decompress one structure while putting traction strain on another. So before we talk about what to do, we need to talk about what's actually going on inside yours right now. No equipment, 3 tests, each one a clue. Start with your arm hanging at your side, completely relaxed. I want you to slowly raise it out to the side, not in front, not behind, directly out like a wing, and tell me where it hurts. Specifically, at what angle. A lot of patients say it starts somewhere around 60 or 70 degrees and then clears somewhere past 120. That window, that's the pinch zone, the gap between the top of your upper arm bone and the underside of your shoulder blade narrows as you lift. When there's any inflammation in the tendons that pass through that space, or any loss of normal gliding, the bones effectively close in around them. You feel it as a catch, a sharp ache, sometimes a grinding sensation. You reach for a plate in the cupboard and you already know the motion before you've finished it. You fasten a seatbelt and adjust quickly to avoid the angle. Pay attention to that, the specific arc, the height at which it appears and disappears. That tells you something precise. This is called a painful arc test, and if it's positive, Ricky, if you felt that catch in that specific window, we're most likely looking at subacromial impingement, not a tear, not structural failure, a problem with space and positioning that we can address directly. Hold that result. Now the second test. This one is more specific. Extend your arm straight out in front of you, elbow straight, and rotate it so your thumb is pointing down toward the floor, like you're pouring a can out. Now raise that arm slightly, maybe 20 or 30 degrees. If that motion produces pain at the front or top of the shoulder, that's meaningful. That position loads the supraspinatus, a single muscle, one specific tendon, running from the back of the shoulder blade to the top of the upper arm. It is probably the most commonly injured structure in the shoulder, and it is not the whole shoulder. That's the part that surprises people. Most patients arrive convinced that something global has failed. Everything hurts, everything feels wrong, the joint feels unreliable. But when the empty can is positive, it's almost always this one muscle driving the symptom pattern. One tendon, 2 to 4 centimeters of tissue causing the whole cascade. The supraspinatus helps initiate every arm lift you make, washing your hair, reaching overhead, pushing open a door. It works before the bigger muscles kick in. When it's injured or compressed, the shoulder compensates by recruiting incorrectly. And over time, that compensation becomes the problem. You don't just have a sore tendon anymore. You have a shoulder that's forgotten how to sequence. Third test, stand near a wall for support and bring your elbow to your side, bent at 90 degrees, forearm pointing forward. Now try to rotate your hand and forearm outward, away from the body, like turning a doorknob outward. How far can it go? Where does the resistance come from? Compare left to right. If one side moves significantly less, or if the movement creates pain or a sensation of tightness wrapping around the back of the joint, your external rotators are involved. The infraspinatus and teres minor, two of the four rotator cuff muscles, are responsible for outward rotation, and they are dramatically undertrained in most people because most daily movements load the shoulder inward. Picking things up, carrying, reaching across the body, sitting at a desk with rounded posture, all of it shortens the front and neglects the back. Here's where the reframe matters. A shoulder that can't rotate outward doesn't just have weak muscles, it has altered mechanics. The ball of your upper arm isn't centering in the socket the way it should, and that changes how every other structure loads. The impingement that lit up in your painful arc, the tendon irritation that showed up in the empty can. Both can be downstream consequences of this rotation deficit. That's the point. Now look at what you found. 1 test positive, you have a specific starting place. 2 tests positive, common, not catastrophic. More than one structure is usually involved, and the pattern still points toward a treatment sequence. All 3 positive? That tells us the whole shoulder complex is under stress and sequencing poorly. But it also tells us that working systematically through each component will address more than it appears to. Nothing about this is hopeless. Everything about it is specific. If your painful arc test was positive, the first priority is decompression, creating space before you load. The pendulum exercise, standing, braced against a table, lean slightly forward and let your arm hang completely loose. Let gravity do the work. Small circles, forward and back, side to side, not swinging, barely moving, 20 to 30 seconds. The logic here is that passive hanging gently distracts the joint, creating length in the capsule and reducing the compressive force on the impinged tissue. You are not stretching, you are offloading. There is a difference, and it matters. After the pendulum, table slides. Seated in front of a table, forearm resting flat on the surface. Slowly slide the arm forward along the table, letting your trunk follow passively. No forcing, no reaching. The slide should feel like release, not effort. The common mistake here is adding shoulder elevation at the end. Don't. The moment you reach for more range at the top, you reload the impingement zone. Stop at the point of mild tension and back off slightly. Then shoulder blade squeezes, sitting or standing, arms at your side, gently drawing the shoulder blades toward each other and slightly down. Hold 3 seconds, release fully. This is not about strength. It's about restoring normal scapular position so the roof of your shoulder complex isn't tipping forward and compressing what's underneath. If you've been rolling forward at a desk for years, this will feel like nothing. Do it anyway. If the empty can was your clearest positive, you're working with the supraspinatus. And here the word is patience. More than any other shoulder structure, this tendon responds poorly to overload and well to carefully graded loading. Start with wall slides. Standing facing a wall, forearm resting against it, gently slide the arm upward, only to the point where you feel no pain. Hold the top position. For 3 seconds, that's it. The controlled eccentric return, sliding back down slowly, is where the tendon adaptation happens. Do not push into discomfort. The 30% effort principle applies everywhere in this section. If you think you're working hard enough, you're probably at 60. Drop it. Add isometric pressing after a week of wall slides. Standing, elbow at your side, press the back of your hand gently into a wall in the empty can direction. No movement, just sustained pressure. 5 seconds, 10 repetitions. The joint doesn't move, the muscle activates. This is how you load a healing tendon without provoking it. A lot of patients skip straight to resistance exercises because they feel ready. The tendon is not ready at the same time the pain decreases. They come apart at different speeds. This is where re-injuries happen. If the outward rotation test was your clearest finding, start with assisted rotation. Lying on your back, elbow bent to 90, use your opposite hand to gently guide the forearm outward, letting it fall toward the floor slowly, stopping at the first point of real resistance. Hold 10 seconds. Let the weight of the arm assist the stretch, not your pushing hand. Most people push. Don't. You're not trying to override the restriction, you're inviting the tissue to release over time. After 2 weeks of that, introduce isometric outward holds. Elbow at your side, press your forearm outward against a door frame or a wall. No movement, 5 seconds both sides, 10 repetitions. When this feels effortless, truly effortless, you add a resistance band. Not before. Before we get to the action plan, drop a comment and tell me which test was positive for you, and whether it matches the pain pattern you've been dealing with. I want to know what you found. Now, 5 situations where these exercises are not where you start. If your pain came on suddenly after a fall, a tackle, or a wrenching motion, get imaging first. If you have pain at rest, significant pain at night that consistently wakes you, or pain that doesn't vary with position, that pattern needs clinical assessment. If you've had a sudden and noticeable loss of strength, not fatigue, but the arm simply not holding its usual load, that's a red flag for a full thickness tear and warrants an ultrasound. If your pain radiates down the arm towards the elbow or into the fingers with any numbness or tingling, the cervical spine needs to be ruled out before you treat the shoulder. And if you've been doing appropriate, well-paced rehabilitation for 6 to 8 weeks with no meaningful change, that's the information a clinician needs to redirect treatment. These 5 scenarios are not alarmist categories. They're clinical patterns. If you're in one of them, the exercises above are not your starting point. They're your eventual destination after proper assessment. Your 7-day starting point. Painful arc test positive. Begin with pendulum swings and table slides every day for the first 7 days. Nothing loaded, no resistance, pure decompression. Retest the painful arc at day 7 and notice whether the window has shifted. Empty can test positive. Wall slides every other day. 10 repetitions. Living at 30% effort. Outward rotation test positive. Assisted rotation daily. Isometric holds beginning on day 5. All 3 positive. Start with the outward rotation protocol first. It underpins the other 2. Restore position before you restore strength. At day 7, stand at a mirror and redo all 3 tests. The goal is not to be pain-free. The goal is to notice whether the quality, location, or intensity has shifted in any way. A change, even a small one, is data. It tells you the structure is responding, that you've found the right level of stimulus. Let your arm hang at your side right now. Let it be loose. And slowly, just to the side, just into that arc, notice where the catch is today. Mark it. That's your baseline. Not a diagnosis of something broken. A starting point for something that now belongs to you.